Thank you, Dr. Ashwaq, for these invitations. And I was asked to speak about the immunotherapy in colorectal cancers. And let's start with these questions, actually. Who's the one doing the MSI? When do you test for MSI for patients with colon cancer? Only a patient at diagnosis, all the patients. Only patient with early stage. Only patient with metastatic disease, or only patient with strong family history of Lynch syndrome or VAB. Ashwaq. So number 3, Ahmed, Fuad. Okay, Dr. Shawqi. Third line or fourth line. Okay, excellent. Good. Fair enough. So we know the colorectal cancer tumor progressions started from initially from simple polyp, then it's going from advanced polyp, then transfer to malignancy, then metastasis. And we know the MSI carrying the most important thing in this stage, in this place here. This is where the MSI play the major role. And we know the colorectal cancer carcinogenesis play a very important type of the pathway. And the most important immunotherapy area is targeting the MSI pathway, although the number is 15% for all comer of colon cancer patients. Now, we know the idea of microsatellite stability and instability, and I'm not going to discuss about it. There is a very important terminology, the difference between the MSI and it's again deficiency in mismatch repair, and the same thing, replication or positive, and it is exactly, it means the same thing in the right side, microsatellite stable disease or proficient mismatch is again the same story, and what's called replication error negative, it is the same story, and always we find it in a lot of our literatures. So, it's carrying almost 15% of all the patients with colorectal cancers. However, if you dividing the patient from stage 1 to stage 4, you can see in the stage 4 is almost 4% only. And very important to understand that in stage 1 to 3, it's a good prognosis. And usually they don't respond to the 5-view. This is only in adjuvant setting. While in the metastatic, actually it's carrying very poor prognosis. And usually in the right side. And because of the microsatellite instability, this is going to form the new antigen, and this new antigen going to stimulate the immune system, and the immune system going to be stimulated, and it is an area of targeted by immunotherapy. We know this clearly. The BDL1 and the BDL, when they attach to each other, there will be not recognized by the lymphocyte, a T lymphocyte, and once you break that one, the relation between the BDL1 test, it's going to be recognized by the T lymphocyte and going to be attacked and targeting the cancer cells. The story started from a very simple number. If you can see, only 38 patients, and it was published in New England Journal of Medicine. And if you can see, those who has an MSI, see the response, we reached to almost 40% in briefly treated patients with metastatic colorectal cancers. And disease control, 90%. Those patients actually in second and third line of therapy. Now, if you look at the progression-free survival, it's huge. It's separated, very nicely. I can get between the two curves here. And again, the overall survival is very huge, as you can see, with remarkable improvement in patients only with MSI. And subsequently, the Checkmate 142, when they use the cohort A with histologically confirmed metastatic or recurrent colorectal cancer, MSI high, and they randomized to all the patients to nivolumab, and they divide the group subset analysis to group A and group B. Group A, those who receive more than 3 lines of therapy, and group B, who they receive in second and third line of therapy. And the primary endpoint was overall response rate. Now, if you see, very important here, they include also the BRAF mutant type, and if you can see, is almost 11 to 16, between 16 to 11% on those category of patients. And if you see the prior therapy, actually most of the patients actually, as you can see, it's in those who receive more than 3 lines of treatment. and look to the overall response rate. For all the patients, it reached to almost 34. And if you look for the group A, who receive 3 line, it's 26. And those who receive more than a line, they reach to the 52%, which is huge. Now, if you look at the duration of the response, it does not reach in all the patients. Again and again, those are the patients that receives 3rd and 4th line of treatment, and the stability of the disease, it's 8.3, 8.5, and as you can see, it does not reflect, although the response was 52, does not reflect in the overall survival, in the median duration of stability of disease with 5.3. Again, if you can see, remarkable response for both group A and B, and the overall response rate, this is the updated analysis, for 13 months was 32, and this is in the last ASCO 2 weeks ago, it is again 34 disease. With the most important striking thing, the complete response. The complete response reached almost to 10% with updated and following the patient at 21 months, and disease control was almost 62%, which is something tremendous, huge. We never reached to this in 3rd and 4th line if you compare the TAS or regorafenib. Now, again, the nivolumab continuously to provide clinical meaningful and durability. It was the most important thing, and we can reach now to 132 weeks. It's huge duration of response. And in terms of the progression-free survival, 6.6. The regorafenib and the TAS was 1.6 and 1.9. This is 6.6, which is something huge, Prof. Jazia, for medical oncology that we're treating GI. And if you look at the overall survival, the median overall survival, in the cutoff analysis, they did not reach in 3rd and 4th line. It is something tremendously, and it's huge practice. The only limitation is a small number of patients for the analysis. Now, again, the overall response rate, as you can see, the complete response and partial response and stable of disease, all of them, they did not reach with updated analysis. There was no striking about the safety, any signal in the long-term follow-up. And basically, the main issue was major fatigability, which is actually, as you can see, is not very huge in terms of grade 4. It's only 1%, which is, frankly, we can say it is safe medications. So the conclusion of that trial, it showed clearly nivolumab in the follow-up of 20 months, it's improved progression-free survival, overall survival continuing, and the complete response, we reached almost 10% on those category of patients, and median duration of response and overall survival was not reached yet, and this is going to be evaluated in the first line setting. The other trial, when they add the 2 medication, nivolumab plus ipilimumab, which is actually one of the dangerous combination with a lot of toxicity, and basically the same thing. Histologically confirmed colorectal cancer, MSI high, they randomized all of them to this combination treatment, and they were looking for overall response rate, and it was actually updated in the last ASCO. Again, as you can see, they include also the BRAF mutations, which are almost carrying now almost 24%. And if you can see, most of the patients actually, they were in 3rd line setting. And if you look for the overall response rate, it is 55%. And if you compare it to the nivolumab arm before, it was only 31%. So the combination therapy add more. However, in terms of toxicity, we're going to discuss this later on. And again, the same thing, the duration of the response is not reached for the analysis of this trial. And basically, until the result, 94% of the responder had ongoing response. So 94%. Now, regarding of very important, even the BRAF patients, it seems that they respond. Even those who has KRAS mutation, wild or mutant, they still respond to the combination therapy. And if you see the progression-free survival, it's a very excellent, nice separations, with almost 76 in 9 months and almost 71 in 12 months. If you compare to the nivolumab alone, 54 and 50. And again, if you see the overall survival here, 87 they still survival at 9 months, and 85% they still survival at 1 year. Remember those who's briefly treated. And if we compare to the nivolumab, slightly better. Now, patient-reported outcome actually, in this trial, patient showed remarkable improvement in terms of the quality of response. Now, the side effect of this combination therapy, it is not, as we said before, it is, you remember nivolumab and ipilimumab when they added to the renal cell carcinoma, Shawqi and Ahmed, it was showed huge, side effect. Now, this is not true in the colorectal cancer, when we cannot explain why, although this is again and again, it's only phase 2 trial. And if you can see, the grade 3 and 4 for diarrhea is only 2%, and most of the problem actually is increasing ALT with 8%. So, in conclusions, it's higher overall response rate, durability of response, high control rate, and very encouraging overall survival, and progression-free survival does not reach, and 85% still alive in 1 year, which is something tremendously huge. Now, what about the MS stable disease? So we speak about the MSI high, and it showed clearly nivolumab and pembrolizumab, both of them that are approved now by FDA to be utilized in metastatic colorectal cancer with high MSI. What about the MS stable disease? Is there any rule for that, for those group? Now, when they look for the trial, it was phase 1B, and after that expansion, they are planning to expand it to, phase 2 trial. Basically, they look for the immunotherapy plus MEK inhibitor, atezolizumab plus combinib, and basically, it's an 84 patients, and look for the majority of patients. 80% they receive 5 lines of therapy, and I don't know what this 5 lines of therapy, usually with 3 or 4, but they give up to 5 lines of therapy, and this is the majority of patients. So if you look for the wild type was 30%, and the mutant was 68, and again, if you see the MSI high is 1%, compared to the MSS, which is our patient usually, where they have almost 50%. Now, in terms of the side effect, grade 3 and 4 is almost 40% when they combine the MEK inhibitor plus immunotherapy. And if you see the response rates, there was no complete response. The partial response was in 8%, and stable disease in 23%. So it's not very striking, the immunotherapy, use of immunotherapy in the MS stable disease. And even if you see the duration of response was almost 8 to 9, and disease control 30%, which is not something striking like the MSI high. It may play a role, but we don't know it is because of the immunotherapy per se, or because of the combinib treatments. And in terms of the progression-free survival, as you can see at 6 months, for example, and all the patient was in 18%. Now, if you see in the KRAS mutant, actually they did better, 22% compared to KRAS wild type, but this not reflecting on the overall survival, as you can see in 44 and 43. It was completely equal. So the combination therapy, it showed, it is something encouraging. It's not very encouraging like the MSI high. And they are going to do phase 2 and phase 3 trial to examine the MS stable disease and the role of immunotherapy plus MEK inhibitor, because I do believe no role of immunotherapy in MS stable disease. So there is a lot of trial going on. A lot of the most important 2 actually is the randomized phase 3 trial with FOLFOX-bevacizumab plus or minuses use of atezolizumab. And the other important trial, actually, the pembrolizumab head-to-head in the first-line setting with our standard of chemotherapy for patients with MSI. Our problem here in Saudi Arabia, the MSI is very rare. We're speaking about 2 to 3%. It's a huge achievement, huge improvement in survival. However, the percentage is only 2 to 3%. And some people, they are wondering, shall we do it for all the patients? Shall we do it, as Shawqi mentioned, in heavily treated patients? Shall we do it in stage 2 and that's it? So there is a lot of trial going on immunotherapy in metastatic colorectal cancer. I think the combination therapy, it may play a major role later on, hopefully with less side effect. The answer question, what's the best chemotherapy combination? Is the FOLFOX/FOLFIRI chemotherapy? Or what is the best sequencing, where we should put the immunotherapy in first, second line, third line, and what we should do after the immunotherapy, and what the effect with the radiotherapy. There is a lot of trial in head and neck, for example, and another trial, phase 2 trial in rectal cancer with radiation treatment, and still we are looking for the results. What about the targeted therapy, and what about the combination of BRAF? They do believe that immunotherapies play some role in BRAF mutant based on the evidence we have. Again and again, this is a phase 2 trial, and it's not huge of number of patients, but the result was actually very striking and tremendously improved in those category of patients. So the last questions for you, Ya Ahmed, because you're looking for the phone. Ahmed, can you? You have identified 39 female patients with metastatic colorectal cancer with MSI high, and this is in first line setting. What's the best way? When do you put nivolumab or pembrolizumab in your equation? Excellent. Fair enough. So last week I received a patient who was coming from the private clinic with MSI high. He's almost 65 years old. And according to the report, the patient is not for any chemotherapy, not fit for targeted therapy. And so for that, I'm going to prescribe for him immunotherapy. Shawqi, do you agree with this? No. According to the report, the patient cannot tolerate the chemotherapy. This is the report. So do you agree or disagree, Shawqi? So the patient is not fit for chemotherapy because of his... Excellent. This is the message that we would like to relay to everyone. Okay, جزاكم الله خير. شكرا جميعا.